need to start then, Matthew, please. Thank you. And welcome to the West Yorkshire Joint Health Overview and Scrutiny Committee December meeting. Do we have any apologies from of committee members who are not able to attend today?
We've got apologies from Councillor Blackborough.
Thank you. Any other apologies? No? Okay, thank you. Minutes of the previous meeting then. Do we approve the minutes of the previous meeting? If members of the committee can just indicate. Yes, thank you. Thanks, thank you. Are there any matters arising from those minutes that anybody wishes to bring up at this point in time? No? Okay, thank you. Are there any declarations of interest that anybody needs to? If there's anything that comes up during the meeting, please fill in the papers in the usual way. Okay, so we don't have any notice of public deputations or petitions.
None received, Chair.
So we move on to the agenda now. We have a slight rearrangement of the agenda this morning. So we're going to take life expectancy first, suicide prevention, and then the non-emergency patient transport services. So we will move to life expectancy. Ian and Kia, which one of you is going to start with this then, please?
That's going to be me, if that's okay. So morning everyone. So my name's Kia. I'm the Programme Director for Mental Health, Learning Disability and Autism across West Yorkshire. So I'm going to talk about life expectancy, particularly within the context of that population cohort. So I'll do a bit of a spiel. There is a paper attached within the pack, which also linked to another paper we took to our Integrated Care Board a while ago, which details a bit more information, and then happy to take any questions. So across West Yorkshire, one of our 10 big ambitions is about reducing the gap in life expectancy between people who have mental health conditions, people who have learning disabilities, and people who are autistic compared to the rest of the population. And the reason for that is that we know on average, people with a severe mental illness are likely to live 12 to 15 years fewer than people who don't have a severe mental illness, and people with learning disabilities or autism are likely to live 14 to 18 years fewer than people who don't have a learning disability and or autism. And broadly speaking, the reasons for that can be divided into kind of two main categories, really. The first is that that cohort of people are at increased risk of physical health conditions because of the different risk factors or medications or treatments resulting from their mental illness or resulting from the fact they have a learning disability or autism. So they're more increased risk of physical health conditions. The second factor is that we also know those people are much less likely to get access to care when they need it, and care that responds to their needs and makes the adjustments for them given their kind of condition or given their diagnosis. So they're the two main broad factors in terms of how that contributes to that gap in life expectancy. It's not always a really easy thing to measure with available data about how are we doing delivering against that gap in life expectancy. So we do have some publicly available public health data now that didn't exist in this form previously, which does describe the mortality gap between people with severe mental illness and people without. And really, really helpfully, we know that is now broadly improving over time. So when we look at deaths for people with severe mental illness for things including cardiovascular disease or respiratory conditions or liver disease, we can see over time that is starting to drop, that kind of gap in life expectancy. Interestingly, when we look at conditions like cancer, broadly speaking, there's not much of a change over the past kind of decade or so. But we have historically and still continue to also need to use proxy measures to try and understand, are we making the right contribution to the reduction in the gap in life expectancy. So for example, we also try and focus on things like, what are the smoking rates like for people who have mental illness or who have learning disabilities? Are those people getting access to health checks that enable people to understand kind of what their broader health looks like? So we try and track some of those things too. So what we tried to do in the paper is frame a little bit of it in the context of what happens in terms of the three kind of groups of prevention, really. So what happens in terms of primary prevention, so what happens at the diagnostic and treatment level, what happens in terms of secondary prevention, so what happens in terms of, what happens in terms of primary prevention, so what happens in terms of the wider determinants of health, what happens in terms of secondary prevention, so what happens in terms of diagnosis and treatment, and what happens in terms of tertiary prevention, so that prevention of exacerbation of illness when it kind of takes place, and outline some of the West Yorkshire wide work that fits into those categories. Now, what we haven't done in that paper is kind of list the whole range of things that happens in our providers and in our places, which an awful lot of work and an awful lot of stuff that happens in the health and care system obviously contributes to this agenda. So the things I'm just going to briefly mention, which we talk about in terms of primary prevention, are two particular examples that we've been looking at over the course of the past kind of 12 to 18 months or so. So one in particular, we know that one of the big factors that drives kind of wider determinants of health is housing. And in particular for our mental health, learning disability and autism population, that is a really key factor. So do people have availability of safe housing, housing that keeps them safe, keeps them warm, keeps them healthy? And even practically, we have real challenges in being able to help people who are coming out of inpatient mental health or learning disability settings into appropriate housing for them and their needs, which sometimes contributes to the fact that people stay in kind of inpatient settings longer than they need to. So there's a bit of a focus on trying to understand what is the gap in terms of the kind of the housing provision that we need across West Yorkshire, looking at each of our different places for that particular population cohort. And the second bit in terms of primary prevention is thinking about how functions such as our West Yorkshire Staff Mental Health and Wellbeing Hub supports resilience within our own health and care workforce, and how that is therefore a factor that helps people who work in the health and care sector to maintain their own kind of mental health and well-being. So the second chunk is then about kind of secondary prevention, so that bit about kind of diagnosis and treatment. And there's a few areas within that I'll just briefly touch on. So the first is recognising the significant challenges we've got around waiting times for things like autism and ADHD diagnosis. So how do we both identify ways to make those diagnostic processes more streamlined and more consistent across West Yorkshire, because there's a lot of variation at the minute, but just as fundamentally, really trying to ask the questions about all parts of the system, which is basically the so what question. So once people do receive a diagnosis of autism or ADHD, how are they supported post that diagnosis, and what support can be provided to people who don't have that diagnosis and are waiting at the minute and therefore need support whilst they are waiting? And a lot of that conversation inevitably goes way beyond health. It's about kind of societal input, particularly for young people and for children. It's around education. For adults, it's often around their employers and the relationship they have with their job. The second area within kind of secondary prevention is a lot of work to understand and try and delve into the focus on racial inequity, and particularly within mental health settings. There's a real push at the minute nationally from something called the Patient and Carer Race Equality Framework. So this is basically a national expectation that says we expect all providers of mental health services to go further than they ever have done before to really understand the needs of their population from a health inequality point of view linked to race, and to make some significant changes in how we not just understand that population, but respond to the different needs that they have. And some of the work we've been doing across West Yorkshire in the past, again, 18 months or so, has included rolling out what we call cultural competency and humility training. So the training that allows care professionals to try and recognise culture, to understand that everybody has culture and that we respond to the needs of people differently as a result of that. And then beyond that, you probably wouldn't be surprised to say, when we're thinking about kind of diagnosis and treatment pathways, there's work that goes on in a whole range of different areas. So it could well be, how at the minute are we responding to the need to provide particular support to young people who are wanting to go through gender reassignment, and the impacts that has on their kind of mental health. What are we doing to respond to national policy around ensuring people get access to mental health crisis services via the 111 service? How to improve and enhance services such as eating disorder provision from a preventative and a treatment point of view? All of which, you know, are kind of building blocks in terms of trying to improve that point around reducing the gap in life expectancy from a kind of a service point of view. And then finally, in terms of tertiary preventions, that bit about trying to prevent exacerbation of illness, or understanding of when we've kind of when we know that people have died earlier than they should do. There's a focus in learning disabilities, particularly through a program called LEADER, which basically is called the Learning from Death program for people with learning disabilities. And what that means is that any person with a learning disability who dies, there is a review undertaken of what was it that contributed to their death, and in doing that, working backwards to say, are there opportunities that could have prevented that person from dying as early as they have done, and what are the themes that come out of it. So, for example, in the past 12 months, we've had a particular focus across West Yorkshire on the impact of cancer from a learning disability population, and another conversation and a focused workshop around respiratory, knowing that most people with learning disabilities die from respiratory care. And that sort of learning takes us into other conversations we have between the mental health and the physical health bits of our system, about how do we work together more on understanding and supporting people's needs. So it includes some of the conversation we've been having recently about gastroenterology and the real interface on inpatient gastroenterology wards with eating disorders, with people who might not necessarily have mental illness but certainly have complex needs, who find themselves on an inpatient gastroenterology ward, and what does the combination of work need to be to try and extend the lives of those people and make sure that the lives that they have, whilst extended, are also good and as healthy lives as they possibly can be. And from our point of view, from a mental health, learning disability and autism sector, we have a consultant in public health who is one of my colleagues, and their role is trying to understand the inequalities that are at play for our population, how we make those links with kind of physical health care, how we ensure that we are trying where possible to improve the data we collect, so to know what impact we can have and are having on our population. That all remains a work in progress, but it's, it feels like it's a significant, certainly a step forward than we were kind of 5 years ago when we didn't have this sort of role in place. And then finally, so just trying to, through that conversation and through the kind of paper, trying to give a bit of a flavour of what our kind of ultimate aim is to reduce that gap in life expectancy. A reminder, I suppose, though, that some of the impacts for people in terms of improving their life expectancy will definitely be driven by direct experience of services they receive from health and care, particularly in this context, mental health trusts, voluntary and community sector partner organisations, but also, of course, the services that primary care, local authorities and acute trust provide. But it is worth emphasising, as I think colleagues will all be aware of, that there's even more impact in how those services work together for this kind of population cohort, and way beyond that, some of the widest impacts in terms of impacting health for the population that kind of I'm here to serve and colleagues are here to serve go much wider than this as well, and it's about societal stuff, so that the links to education, the links to employment, the links to housing and the environment, etc. Yeah, so that's a bit of a summary. So in broad terms, we can see some elements even in the data of progress and improvement in terms of that gap in life expectancy. It's not a neat art or even a neat science. We're still trying to make sure we collect the right data in the right way. There are lots of initiatives that are contributing to try and deliver against that agenda, some which are kind of directly about that and direct about improving kind of inequality, and some is just the way in which services are provided that contributes to reducing that gap. But I will stop there and hope that is helpful as a bit of an introduction, and then happy to take any questions and get into a discussion.
Thank you very much. Are there any questions from the committee? Councillor Hutchinson.
Thank you, Chair. I've become aware of concerns been raised by quite a number of residents in my borough, which is Culverdale, about the way in which care is provided in supported living and other residential settings, particularly for people with learning difficulties. And I mean, currently, 1 in 6 of the children going through our educational system is identified as having special educational needs or having an EHCP. So it's a significant part of the population. But those who are ending up in residential care or supported living, that there doesn't seem to be the attention on the commission, from the point of view of the commissioners, to make sure that cultural sensitivities are embedded within the care plans and the monitoring of the delivery of those contracts. And nor is there for people with other learning difficulties, because this isn't purely ethnically related. That the people who are actually responsible for delivering the care are often on minimum wage, transient population, transient workers, possibly agency workers, but certainly not often long-term workers. There are some very good carers in amongst them, but a large proportion is from people who we as a society do not value in terms of their training requirements, their pay, their other terms and conditions, and the expectations that we have of them. And similarly, the people who manage these placements, these residential placements or supported living, don't seem to have that understanding either. So it's fine the health and care professionals having the training and awareness, but that doesn't seem to be actually translated into the care that is actually being delivered to these most vulnerable people in our society. And I was wondering whether there is any good practice that is developing or clear places that are getting this right, or whether my belief is that it is a national problem. But obviously I'm only becoming aware of it at a local level. But if people with, it's fine identifying that somebody with learning difficulties has ongoing health needs. But if the people who are actually delivering that, looking after them and monitoring the situation don't understand anything about those, then they're not going to pick up on the signs when things are going wrong.
Kia, do you want to come in?
Yeah, thank you. It's a really helpful, question and statement, actually. And I think your point around it is a national problem is probably true. I think that there will be issues up and down the country. I think the one thing I could say is if I think about how there's been a bit of a movement or a change in a acceptance that all people in health and care who are delivering care or even commissioning care need to have a better understanding of the needs of people with learning disabilities and autism, for example, which probably we didn't have that acceptance 5-10 years ago. So one of the key things that nationally we are being rightly asked to do as a integrated care system, and it is an integrated care system, so it's not just about health, it is about VCSE provision, it is about local authority provision and providers of care, is to try and roll out something called the Oliver McGowan mandatory training. So this is basically a set of training for anybody working in health and care. There's a bit of the training which is about frontline professionals who deliver care, and there's a bit of the training which is about back office people who still need to understand what it means to have learning disability and autism, is to roll out that training package. It's not easy to do, and there are barriers to doing it, because it doesn't come with any recurrent funding, but we're trying to work through as a system with all of our partners how we make sure that everybody who needs that training does get that training, and it is rolled out. Now, that is part of an answer that doesn't solve that whole conundrum. And I think that there are obviously wider issues at play about the transient workforce, about the level of pay, and about the ability to retain staff in those settings. And not dissimilarly, we have similar conversations within the mental health space as well, where actually our workforce is comparatively paid on NHS scale, so is much better paid than your average kind of care worker. But there are still issues with recruitment, and there are still issues with retention, partly because about the challenges of the job and the nature of having to support people who really do need an awful lot of support, and the emotional toll that takes on people and their ability to kind of carry out those functions. So we're trying to do an awful lot of work in terms of retention of the workforce within the mental health, learning disability and autism settings. I can't really speak in the same way about kind of social care colleagues or kind of care providers, but I do know that those conversations do happen And there's a real recognition that that is an issue that we have been trying to look at across West Yorkshire, and historically have tried to make sure that when we're having those discussions about funding or about impact, trying to improve health outcomes, it is about the totality of the system and what we can do to support social care colleagues as well. So it might not help entirely, but just to kind of say there's a couple of bits in terms of training that are definitely happening. There's a recognition of the wider issues in terms of the workforce. But I'm not sure I've particularly got an answer about how we solve all of that bit, other than to say that there are, it is acknowledged, and I think your point is completely valid.
There seems to be a lack of objective setting when people are put into accommodated in long-term residential care. And I'm thinking particularly of younger adults. There seems to be a lack of setting of objectives as to how they are actually going to get the most out of their lives, contribute the most to general society. They're essentially being warehoused. They're just being sort of put somewhere without opportunities for development of their potential. And and how do we know how effective care is unless there are objectives against which we measure that?
Keir?
Yeah, I think on that final point, a lot of that feels like it boils down to really, really good personalised care planning, if that makes sense, understanding of the needs of that individual, and I'm not to put too fine a point on it, but what the point of it is wherever they are. So if they're in an inpatient mental health setting, why are they there, and what's the expectation about benefit? If they're in a residential placement, why are they there, and what's the expectation about benefit, and what the kind of the aim is and that trajectory for that person that's agreed with them and they contribute to. And there's a recognition that that works well in pockets. And coming back to your previous point about, there is good practice where that definitely does happen and definitely does work. It won't be universal to all kind of, all bits of the system, but it does happen. And I think that then that bit about tracking progress can be tricky, I think. And the reason for that is, if I think, again, specifically about the mental health world, generally, from an NHS point of view, what we get judged on is access to stuff. So the number of people getting access to a service is what we'll be judged on. There is a big push, and everybody across the sector is desperate for flipping that on its head and trying to tilt it to the outcomes-based stuff. So not just the number of people who get seen, but have the outcomes been good for that person at the end of all those kind of interventions. And if I think about something like talking therapies, again, kind of 5 years ago, the focus was purely on the numbers through the door. Now, the focus is still a little bit on numbers through the door, and it doesn't it's likely to change anytime soon, but there's more of a focus on outcomes at the end of the day. And similarly within community mental health, there's more of a focus on kind of outcomes. So definitely not there yet, but hopeful that that is the direction of travel, to trying to capture and measure those outcomes. But I think, at the minute, for most people in a kind of residential setting, I'm not sure that, again, that's what we'll be capturing and that's what we'll be kind of able to monitor. But it's moving in the right direction.
All right, thanks. Councillor Scopes.
Thank you very much. I think I've got 2 comments and 2 questions. So I welcome what you were saying here about the wider determinants of health. I think that's really important thing to talk about. And I think when you talk about that, you think about wider things like housing and jobs and that sort of thing, and that availability, and that is fundamentally important. So that's my first comment. I think the second one is around supporting schools, and I think there's been a real challenge, certainly in Leeds. I can't speak for the rest of West Yorkshire, but there's certainly been a challenge around funding, getting EHCPs through, making sure that basic educational piece is done and is done well for young people, because that'll affect their future outcomes fundamentally. And I think there's a major challenge around academies in particular doing massively reduced timetables. And I know that's not an NHS thing specifically. I'm not, that's why it's a comment rather than a question, but I do think we as a health scrutiny committee as a whole need to take note of the wider issues. And if we don't grapple with each of them, and we don't recognise there's a joined upness about this, I think we're fooling ourselves. When we talked about recently in my scrutiny board in Leeds, we talked about the 80-20, so the healthcare being able to do 20%. And I don't know if that applies to this group so much, but I think that's worth saying. But I think we need to do more on that as a system. So my two questions. The first one is around healthy life expectancy. So in Leeds, we've started looking at healthy life expectancy, and shockingly, the gap in Leeds between life expectancy between the most affluent and the least affluent is too high, but the healthy life expectancy is even higher, which is devastatingly sad and something we need to look at, and that's where the wider determinants come in again. I just want to know if you, so my first question is, are you looking at healthy life expectancy as well for this group? Because I think that's really important angle, because for obvious reasons, I think it's important. The second one is just around assessments. And I've touched on assessments for children, but I guess assessments for adults as well. We've recently talked about this in Leeds, so it's public knowledge, and there's people in Leeds maybe waiting for a long time before they get their neurodiverse assessment. And so I guess just some comments, interested in your views around that. And I guess my assumption is that generally, what's your bar for who's included in this data? And my guess is I don't want to start labelling higher and lower level, and I'll look to your expertise. But I guess, is your assumption that people who are not assessed must be lower level and therefore wouldn't be caught in your data? How would you frame that? And do you think your data set is accurate, given there's thousands of people on assessment waiting lists, certainly in Leeds, and I assume that's replicated across, I'm seeing nods replicated across different areas within West Yorkshire. Thank you.
Kia.
Thank you. Yeah, if I could start with the neurodiversity assessments first. So if I go right back to that first point around, are we counting that gap in life expectancy and the framing of it and the who? So at this minute in time, if you haven't had a diagnosis of autism, then you're not in those numbers, because you need the diagnosis to be part of those numbers. Now, that goes back to one of the things I briefly touched on, which is through the work we're doing in terms of neurodiversity. So the assessment weights for autism and ADHD are too high everywhere in the country. That is a fact. Now, there is variation in that up and down the country, and we have some variation in West Yorkshire, where some services are set up differently and can do more diagnostic assessments than other bits of West Yorkshire, which is what we're trying to look at with that bit around standardising approach, standardising ways to do the diagnosis. Are we clear about the best way of the diagnostic pathway? But what is also true is that even if we had all the money in the world to do all the diagnostics that we want to do for autism and ADHD, we don't have the workforce in the way that models currently exist to do the diagnosis. So kind of regardless, we know that there's a group of individuals who will be waiting longer than we want them to get that diagnosis. And then it also comes back to the so what question, which was, regardless of whether you get a diagnosis or don't get a diagnosis, have a diagnosis or are waiting, you have needs as an individual. And therefore, the question for us becomes, how much effort and energy is it right to put into the diagnostic pathway? And at the same time, recognizing that even if you go through all that, you may get a diagnosis or not, and still maybe be no better supported to live with the fact that you either have a diagnosed neurodivergent condition or you still have needs that need to be met in a different way, which comes to the wider societal point around the impact that has in schools. If you're a child and you therefore need support to progress with your education, or if you're an adult and you need support from your employer to make reasonable adjustments to understand kind of your needs. So yeah, so that kind of, there is kind of a lot of that tension at play, really, about the fact that we are trying to work through consistency, best use of the funding we have got, best use of resources, and actually trying to look at pushing back a bit on some of the restrictions around diagnostic criteria. So what can we do better with partners in primary care, rather than needing to refer into a specialist service to do the diagnosis, try and unblock some of that stuff. And then on the healthy life expectancy bit, so the honest answer at the minute is that's absolutely the right thing to be looking at. Because it's not just about, who dies at the end of the day. It's about kind of, the ability to live well whilst, for your life. The challenge we have got, again, is it's even more complicated to try and calculate the impact of that, and how do we know who's having a good life at West Yorkshire level at the minute within the kind of the infrastructure we've got. But it's something we want to try and progress towards, to be able to count better and to count in a kind of consistent way. But I can see Ian's going to come in on that point, I think.
It was just, I mean, I completely agree the point that the councillor makes. Healthy life expectancy, we believe, is a more meaningful measure. We can't do it for this yet. When we talk about ambition 1 of the 10 big ambitions, we do, which is looking at variation by socioeconomic status. We do have that information by healthy life expectancy, and that's the measure that we use. So to data availability, Councillor Scopes completely take the point.
Okay, thank you. Do you want to come back, Councillor Scopes, or is that okay? That's okay. Councillor Ryler.
Thank you. I wanted to come back to housing because, as we all know, it's so important in terms of general well-being and feeling safe. And clearly the government has targets for house building, but I guess what I don't know is, are there targets for building houses for people with additional needs? And is this something that you would discuss with local councils or discuss with the government then as well going forwards? This is maybe asking other people as well. Do you know about targets for housing, not just the number of houses, but more specifically housing for people with additional needs? For example,
maybe Ian, from a wider perspective, is that something that the ICB have conversations
It's not something
about?
we have direct control over as an ICB, and to be honest, I don't know the answer to the question the council is asking. It seems like a eminently sensible question to ask. What I can do, councillor, is take it away and have some of our conversation with our colleagues at the combined authority and just get a bit of a sense of where things are on that, because it's a very reasonable question to ask. I just don't have the answer at my fingertips, unfortunately.
Yeah, that's fine. Okay. All right.
Yeah, no, that's fine.
Yeah, Councillor Rhodes.
Thank you, Chair. And welcome, Keir and Ian again. I have listened patiently and very interestedly in the discussion from Keir. And my background is I worked in a mental health hospital for over 20 years. And the agenda then was care in the community, as you will all probably remember. And that care in the community came from an Italian project, which failed miserably, but somehow the government of the day decided it was worth doing. And it meant all the patients within a mental health illness hospital were then diverted to the so-called care in the community, which was set up, supposedly set up, to provide the continuing care for that person in the community in smaller group homes. And indeed, I remember vividly that part of that was an addition, that there would be a revolving door, it was called, for people in the community to return to more in-house supported mental illness needs. Of course, that never happened because times moved on. And my main regret was when I would go in the community as a councillor and I would see people there living in accommodation, even somebody who was mute, trying to work and live in a community without any support at all. And in my days following all of that, I'm still involved in health and healthcare for those in need and healthcare provision and prevention. Prevention is a word that's on everybody's lips, and prevention yet is to be determined on the needs and outcomes that I believe Keir has mentioned. I also, in terms of the young people that Andrew's mentioned, we have a huge gap and an increase in SENDs up and down the district. And we've got these children in some schools, in some academies, who have behavioural problems, who aren't supported. And in some cases, and not all, I'm pleased to say, are excluded from school because the schools that they don't have the support to enable the children or a child with severe difficulties to stay in school. So combine all that with the purpose of the healthy living expectation, and going back to care in terms of your comments on data, the healthy living experience, I would love to see, you've mentioned data several times, I would love to see how the north of England, and I'm being, I suppose, rhetorical in this question as well, actually fares in terms of below the red line, as they used to call it. We have a tremendous problem in our areas across the north here of housing in itself, for housing need in general. And I absolutely have come across situations where we have very vulnerable people who have been placed in what we call houses in multiple occupation, and are supposed to and allegedly get the continuing support in those houses in multiple occupation because there's a housing need, and that's seen as one way of dealing with it. But the second part does not come to fruition. And those people that I've come across who need support in HMOs and who they are increasing at a rate of knots throughout other agencies, I get very concerned about when we're dealing with healthy life expectancies, that it is a headline, but I want to see substance, and I'm not seeing any substance. And I do totally agree with you, Keir, that we got to have outcomes. So in terms of the data that you've got at present now, that we're all aware of as elected councillors out there in our communities, of the need in general, we've gone through times where everybody in the community has come under stresses of various kinds, cost of living, you name it. And we have maybe two or three angles within expectancy needs. We have people who are genuinely in need of better opportunities through employment, and I'm pleased to see that there is outlined plans now for people to get better care and support when they're going to apply for a job. I think we have the second element that you've mentioned, which is those who need more support to get out into our community to feel valued. And I don't believe that that's there at all. I think the emphasis is there, the need is there. But because of the financial constraints that we've been under, and as Andrew has mentioned, assessments are taking that long that it is actually the individual, they are deteriorating and feeling that they're not part of society. So we've all this data, and I know Ian is listening attentively. Where does that data go? What priorities do you put on it in turn? And this is a wide question, because speaking to somebody about priorities, when there's such a wide gap at the moment, how do you prioritize your data in terms of going forward through the ICB back to place for allocations of funding? Is that a mechanism that's built into your portfolio? Is this something that actually, when we look at the statistics, will gain some priority at the ICB board back to place? When we get back to place, and I thoroughly agree with your views of the role of GPs, not having to put somebody on an assessment for 18, 20 weeks, maybe even more. I thoroughly agree with the role of the prevention element that could be and should be used within GP practices. And I'll be very liberal with this because I don't think it applies everywhere. Rather than it's a prescription and we'll see you in a month or 6 weeks. That's as bold as it is at the moment to help people out there who are struggling. And I really would want that engagement between yourself, the other organisations that you've mentioned, and indeed my last questions in terms of partnerships and organisations. Local authorities have been mentioned, the mental illness trusts have been mentioned, the trusts have been mentioned themselves in terms of recognition within wards as patient admission process. I would love to see and know if any intervention or I would say maybe reaching out to private organisations who are themselves letting people, they are letting organisations out there who are letting people in one room in their buildings, some very, very vulnerable people, and we speak about training. Is there a reach out to these other providers to find out what's happening? Or is it down to us as local councillors pleading all the time through various departments that building is not safe? What's health and safety doing in there? Can we get enforcement in? And it's not anything to do other than the well-being of the people inside. So is there that process to reach outside the statutory body's care? And if so, how will that go through in terms of your data moving forward that could be then actually increasing the numbers? I come from Wakefield, I represent Wakefield, and I see we're the second highest suicide rate. So is any of that, is there the ability for any of that to be part of your process and your data?
Here.
Thanks. So just to so some of it that you've been describing, I've got to confess, I really don't know the detail of. So when we talk about kind of the links into the state of housing locally in certain areas of what the processes might well be, I think to be assured though, there will be people far better versed in that in each of the local authority teams who engage with their health partners about that end of the spectrum. I think one thing I wanted to pick up on, if it's okay, was that bit about almost the funding and the allocations to make sure it has the best impact. And we know that when we look at the money we get into West Yorkshire, and I'm thinking just specifically the bit that I'm responsible for in terms of mental health, learning disability and autism from a service point of view, we have conversations that are about what should go out to each of our 5 places. So Leeds, Calderdale, Bradford, Kirklees and Wakefield, based on the population that exists, the number of people in those patches. But we're also having conversations about how do we get better and more sophisticated about those allocations based on not just the number of people, but the kind of the deprivation level, or is it different for children than it is for adults? Is it different? Yeah. So we kind of get to a better calculation of who needs the money the most and therefore will benefit the most in terms of kind of setting out those allocations. So that's kind of part of the process to try and make sure that at least in terms of that investment into services, that's done as intelligently as we possibly can do. And then looping all the way back round there is a gap in terms of data and understanding and intelligence across the system, because actually kind of, comparatively compared to an awful lot of, what you might think we've got in terms of capacity at a system level, we need more infrastructure. To do that well, we would need, and I talk about this a lot actually, about kind of one of the most undervalued roles we have as a health and care system is analytical people who can understand the data, help make recommendations and drive how things are done and delivered. And they're relatively hard to get hold of in the health service, because actually compared to kind of the private world, we're not going to pay them the money that the private sector will. So there's a lot of things at play about how we use the intelligence we got, how we make the funding as good as we can do, I think, which I don't think answers all of the points you made, but it hopefully touches on a couple of them.
All right, Ian, really quickly, because Councillor Jamil has been waiting for a little while.
Yeah, I think Kay's covered the point I was going to make about how so the money we get as an ICB at West Yorkshire, 99% of that goes to places, and as Kay's described, we do that based on an understanding of the needs of population. I guess what I'd say within that is that there are constraints nationally. So, for example, the formula that GPs get paid by is a national contract, and we know that doesn't reflect the nature of deprivation in the north as well as it could do, and so that's a conversation that we consistently have with NHS England. But I'll pause, Councillor Smith, because I think Kay's described the way we try and use data to make the allocation.
All right, thank you. Councillor Jamil.
Thank you, Chair. Just a quick one from me around the work you've described in your secondary prevention, and around the work training staff to respond to sort of like different needs of different communities, and you know, supporting residents in that sense. But I think one of the things I would pick up is having just being more aware about the diversity in the workforce as well, so that you know, obviously the diversity of the workforce will be better in terms of providing that care which people from different communities would need. But from your data and your work in this around this, do you feel that there are obvious barriers and disparities in some of the access to care for some of the minority communities? Do you have data around that, and do you feel that that is something that you need to work on?
Thank you. So short answer is yes. There absolutely is data within provider organisations and beyond that talks about those disparities for different communities. So if we look at the data that talks about young Black men, they are much more likely to be sectioned under the Mental Health Act, to enter the mental health system as a result of contact with the criminal justice system in some way, and when they are in our care, are much more likely to end up needing seclusion or to be utilised kind of isolation. So the data does say that. And I mentioned earlier on about the patient and carer race equality framework. That is the framework for mental health trust that basically says the data tells us all this stuff, folks, so we need to try and move the dial on that. Similarly, for other communities, if we think about perinatal mental health for Southeast Asian women, the data broadly says that the number of people who you would expect to be accessing perinatal mental health services from Southeast Asian communities are much lower than their kind of white counterparts. So it definitely says all that. I think that point around the workforce is really significant. So not just the cultural competency and humility training, but we also did a piece of work about inclusive recruitment. So trying to focusing on that point that basically says you're more likely to receive better care from people who look and sound like you, particularly in a mental health setting where that relationship and that almost informal contract is so important to understand kind of cultural needs. So we did a piece of work supported by Touchstone in Leeds about trying to get people from ethnic minority backgrounds into mental health trusts. And a lot of the barriers for them were can't work NHS jobs, don't know how to get in, haven't got necessarily the skills or the kind of haven't ever been helped with the application process. Reasonable adjustments was a big thing, particularly for people who are neurodivergent too, to help them get through the process. And through that pilot that we did demonstrate that really focused work with certain communities was likely to lead to upwards of 80% of people getting jobs from Black and ethnic backgrounds when they wouldn't have done previously. The challenge becomes having the focused resource to really put the energy in and help. So we know what can work. It's having the capacity to do it really well, and Touchstone were a really helpful partner with us in that particular piece of work.
Thank you.
Okay, thanks. I'm going to draw this item to an end because we are actually running behind time now. But I've just got a couple of quick questions for you, just really quick. Are you doing anything around transitions for children and young people? Because delays in changes in education, it already is a traumatic time transition anyway. But for anybody who has delays in that system is going to be even more affected, aren't they? And I'm thinking as well about not just between primary and secondary, but also about post-16, because young people can actually not move easily from one provision to another provision if they have specific needs. And are you working with local authorities for them to be able to understand the impact on somebody's health and mental health on those delays or changes that need to take place? You also mentioned in your report about changes to 111 provision and the access to crisis services in relation to that. And also, so I wanted to know about how that has impacted on crisis services, but also you've got your annual health checks graph in your report, and you're sort of constantly around 75, 78, 79% annual health checks, which seems to indicate you're reaching the same people every year, but you're not shifting that to reaching more people in those health checks. So how are you doing that? Thank you.
Okay, I'll try and answer those quickly. So on transitions, so honest answer is, in terms of that focus of transition from different school ages, that isn't a direct focus for us. Our focus around transitions is where we've got children who are transitioning to adult care. So adult care within the health sector. So if we think about a child who might have an eating disorder, trying to make sure that they get picked up well within their adult provision as part of that kind of transition pathway. Having said that, if we think across West Yorkshire now, roughly speaking, we now have 50%-ish coverage, which is pretty good, but we want it to get better over time with mental health support teams in schools and colleges. So that there's a bit of infrastructure there that is part of almost the mental well-being infrastructure that will help school-age children in transitioning from primary to secondary to colleges as well, which definitely didn't exist 5 years ago. So that's a bit of a help. 111. There's a national policy about ensuring that anybody who goes into mental health crisis can access support via 111. Slightly different response across different bits of West Yorkshire, but broadly speaking, that means that people still can access crisis support by phoning numbers they used to phone if they were in crisis, so local kind of crisis helplines, although it does differ in different places. In terms of the impact, basically we've seen a transfer or a change. So there's now a significant volume of people, more people coming through to crisis lines than ever have done before as a result of that 111 change. But we've seen almost a similar drop in the number of people going through to Yorkshire Ambulance Service, because it's been about how the system has changed the diversion of people coming in phoning 111. So instead of going through to Yorkshire Ambulance Service, they're now going through to crisis teams more quickly, but that's putting intense pressure on that crisis provision way above kind of what we're kind of contracted to deliver, and we're trying to figure some of that stuff out at the minute. And then health checks, it's a bit of a double-edged sword, this one. So broadly speaking, that number, you're right, it's around about kind of 75% in terms of delivering learning disability health checks, is really, really good. And actually, as compared to other bits of the country, we are consistently well performing in terms of even delivering that 75% number. There are two things, though, about that. One is, yes, a desire to try and increase the number of health checks so we do capture everybody who needs them. But there's a more important bit, if I'm honest, which is about what's the point of doing the health check? So there's an ability sometimes to do the health check and the health check be done. But the important bit is, once a health check is done, is that individual followed up with the support that enables them to improve their health? And that isn't captured very easily because it becomes, it's not easy to capture in the data, but that's just as much to our focus as the actual access to the health check in the first place, if that makes sense.
Yes, thanks. I think my thought was that if people weren't receiving that health check, then they wouldn't be in the system to be able to get that support. But and also on the transitions, I think it's important that people in council services understand the impacts of what can happen health and mental health wise for people who may not be able to transition as smoothly as other young people. Okay, thank you. But I'll draw that to a close. Thank you very much. I think there were some items there, Ian, that you were going to check about on housing. So we'll let you have that information. Okay, but thank you ever so much, Keir, for your time this morning. And can we move on then to suicide prevention? And now, forgive me if I say this wrong, but is it Emmeline? Have I said that right?
Emmeline. That's absolutely fine.
I knew I'd get it wrong. It's like my surname. Everybody gets that wrong. So I fully understand. Right. You're going to talk to us about suicide prevention this morning. Thank you.
Yeah. And I realise we're running over time, so I won't give too much narrative at the beginning because you've got the paper you've had with the agenda. So just to say that the suicide prevention programme, obviously we've had a strategy in place since 2022. It's one of the big ambitions for the ICB to reduce, and the partnership to reduce rates by 10%. Previously, the programme was run by Jess Parker, and then Richard James looked after it. So I've got big shoes to fill as the lead now across West Yorkshire, and they've done some tremendous work towards achieving the aim. We do still have critical levels of rates of suicide across West Yorkshire. We're not under an illusion that we've cracked the nut yet, and there's lots for us to do. We know that there's lots of variation across the system in our places in relation to the high risk groups. And we know there's lots of different reasons for that: deprivation, different levels of inequality, population makeup, etc., and the risks and the interdependencies of those risks across. So things like adversity, trauma, resilience, serious violence, and the hotspots for those as well. And then levels of unemployment, which we know are big key risks for suicide. So there's still lots of work to do across the system to understand those variations and how we can really start to make a difference and reduce those rates across each of our places. So if we look at the data, we had 257 lives lost to suicide in 2023, 250 in 22 and 281 in 21. So it is going down, but it fluctuates, and unfortunately it's still not near that 10% yet, so we've still got work to do. We know that there's massive work happening across all of our different places, and some of the examples of that are the suicide audits that happen across places, the real-time surveillance, and the post that we have that sits with West Yorkshire Police to ensure that we can provide good timely postvention support, because obviously the registration times from somebody losing their life to suicide to that being registered, there's quite a delay. I think it's like a 289-day delay, which means that resources can't be applied quickly to either the people, family members, or other people that may be at risk, or when people haven't managed to take their own lives. So our suicide surveillance, our real-time system, allows us to be able to respond much quicker, and we don't always have to wait for those registrations to come through. And we have continued to support that post. It is paid for by West Yorkshire Integrated Care System. So it's something that it is short-term funding though. So it is something that is going to be a risk going forward as to whether or not we can keep that post going. And I know that the places really benefit from data. In Bradford, they do lots and lots of work with the voluntary and community sector, looking at reducing stigma, which is one of the big areas of risk around suicide, and lots of outreach programmes. Particularly around school-based mental health programmes, which links to what Keir was saying earlier. And then in Wakefield, they're really using that real-time surveillance data to get rapid responses out, because obviously they've got the highest levels across the system in relation to suicide. Kirklees are really homing in on their bereavement support offer. We've just expanded the bereavement service, and we're hopefully going to be recommissioning that for another 18 months, thanks to Keir. And then we're looking at the challenges and barriers. The other thing that we're doing with the programme at the moment is we're having a bit of a reset and refresh due to the changes in leadership, and we're looking at the interdependencies with our other programmes. So adversity, trauma and resilience as a cause and causation of suicide, the serious violence and the duty that we have as an ICB. And obviously we've now got the workforce accelerator, and unemployment and being out of work is a big trigger for suicide. So all of those things are really exciting that we can start to pull that together. Some of the achievements we've made across the system over the years, we've got 400 champions now across the system, suicide prevention champions. And another Keir, our female Keir, that is our training provider for suicide prevention, has trained hundreds of health and care staff now across the system as part of mandatory training within the ICB. And we're trying to roll out and replicate that across and combine that with some of our other programmes to develop some training the trainer programmes. So there's lots of work to do. There's lots of work been happening. We are on the way to reducing those rates, but we've still got to be really focused. I'm going to stop there because I know you've not got a great deal of time.
Oh, that's fine, thank you. I know there's a few questions on this item. So, Councillor Scopes.
Thank you very much for this report. I think it's really important focus for us to have. So my question is around ethnicity data, and so we looked at this in Leeds a little while ago. On the 1st of August this year, we wrote a letter to the Chief Coroner raising our concerns about about this point, and just quoting from it, in collecting and analysing data, our records by the coroner, our team noted that there was a scarcity of ethnicity data as well as inconsistencies around merging of ethnic groups in records. And then we go on to say we therefore ask to ensure that this is collected consistently in standardised categories across the system. I guess that's something that we came up with in Leeds, and I guess I'm looking for your support, but also the support of the Joint Health and Oversight Committee to support that as an idea going forwards, and also writing as a Joint Health and Overview Scrutiny Committee to the Chief Coroner as well. But if the ICB could also support that, I think that would be valid. And the reason is, and I'm sure you're on with this, is around understanding who are most at-risk groups, so we can target work appropriately, and we can never target if we don't have the data. And it it's a classic thing. How can you fix a problem if you don't even know what the problem is? And obviously suicide has a massive impact on everyone's lives, but particularly those people closest to people who lose their life through suicide. Thank you.
Yeah, absolutely. I think ethnicity data is an issue across the board. We need to be better across the board at collecting ethnicity data, and absolutely around how we break it down. Because actually we did some work in maternity where we do collect really good ethnicity data, that showed real disparities between different groups within South Asian population. And if we don't get that bit right as well, we can't target resources in the right way. So we'd absolutely support that approach and can connect with you outside the meeting to do that. I think the other thing is that absolutely we're looking at the high risk groups and where they are. So I think it's about looking at other data as well, and where we can overlay that data. So we get a lot of data from the Serious Violence Unit, and they do collect reasonably good ethnicity data. And so where we look at the triggers where we can prevent suicide and some of the risks, and getting that data will be just as important as getting the coroner's data to do it sort of retrospectively. So yeah, absolutely.
Yeah, thank you very much. I'll leave it for the chair to do a motion at the end of this one. Yes, and thank you.
Yeah, thank you. Councillor Coates.
Hi, thanks for the paper. I found it really, really useful. And I'd just like to reinforce your statement about the correlation between unemployment and suicidal thoughts. Youth workers in Bradford West have recently expressed their concerns to me about young adult males in that area of Bradford. And there's been a recent study that's shown that Bradford West and Bradford East are the 4th and 7th worst areas in the country for unemployment benefit claims. So I'm just wondering how we focus our, I mean, obviously I could go to my contacts within Bradford, but are we doing anything to specifically target these sort of areas from a West Yorkshire perspective? Thank you.
Yeah, absolutely. So we're currently reviewing the programme, as I said, and part of that is to do a bit more of an oversight and a deep dive into who our at-risk groups are. And I think that will come down to places to help us identify those as well. I think there's the opportunity with the Workforce Accelerator programme that's coming into the system to look at how we target those younger age groups, because they often do get forgotten. And there is something about education. We know that one of the biggest risk factors, both for suicide, for criminal justice and all of that, is non-engagement with the education system, and then not having that value and those aspirations to be able to achieve and go forward. So I think there's something about how we intervene early, really upstream, and keep our children and young people in school and in the education system.
Yeah, and we've just set up a men's shed as well in that area. So these sorts of, like we talked about, the voluntary sector, the Andy's Men's Club, and I know there quite a lot of these groups are really, really popular now. So there is lots of great work going on out there. Thank you.
Thank you. Ian, did you want to come in on this point?
Yeah, just really briefly. I think it's a really good point that Councillor quotes makes, that the relationship between employment and health, and obviously suicide is the extreme end of it, but we know generally that, you know, people having a reasonable employment, a good job, place to live is hugely important to their general health and well-being. One of the things that you might have spotted in the last couple of weeks is that West Yorkshire is going to be an accelerator for improving economic activity. So we're receiving £20 million from government as a way of, and we'll be giving a target to bend the curve, if you like, reduce the growth in economic inactivity. Since the pandemic, and economic inactivity has been high and it's growing, and the impact of that in terms of prosperity of the region and in terms of health, you know, and well-being, as we're describing, is really critical. So it's a great opportunity to use that funding, and we'll want to target it with communities where we think we can make the biggest difference in tackling inequalities. I think we've agreed with the chairs, Councillor Smith and Hutchinson. We'll have a more detailed conversation on that next year, but I think it provides a really good opportunity to do more active work in this kind of space.
And the youth workers that came to me also mentioned a model that Sheffield have used about having a bus, and they've actually going in, they're going into the communities to try and target these sort of issues. So I don't know. I've, to be fair, they only came to see me the other week, and I've not had a chance to research it. But I don't know if there's any. If you have any involvement with close by areas sharing best practice, but that was just something that they mentioned. But obviously, funding is an issue. Yeah, we do, and South Yorkshire is one of the 3 accelerators as well, so we'll be working really closely with them and sharing practice. Thank you. Yeah, lovely. Yeah. Thank you.
Okay, and did you want to come back as well?
Yeah, I was going to say, so Councillor Coates, I used to drive one of those buses as a youth worker in Bradford, and I used to go into Baildon, Shipley and North Bradford on a regular basis in a bus.
Baildon is my ward.
Yeah, there we go.
Okay,
It was many years ago. But the other thing I wanted to mention is we've just also secured a partnership with Rugby League Cares to bring £50,000 into the system, particularly in Bradford, to work with some of the school hubs around mental health and physical activity, which again, I know it's not directly linked to employment, but it is about understanding young people understanding their worth in other ways. So that's going to have a major impact, we hope.
Lovely, thank you.
Okay, thank you. And also people in debt, struggling with large levels of debt, and there can be in employment, but still struggling with large levels of debt. Is there some work around that as well?
I don't know. I mean, it's early days for the Economic Accelerator, so I'm not sure, Ian, whether it's involved in that, but if it's something we can definitely consider.
Okay, thanks. So I'll leave my question for that, Ian, when we come on to it in a little bit. Councillor Hutchinson, sorry to have kept you waiting.
That's all right. Putting the 20 million of accelerator funding into perspective, I was interested to see from the paper that was presented to the Integrated Care Partnership earlier on this year about this strategy, that the Department of Health estimate that each suicide actually has a financial cost of 1.67 million. And in context with that, there was concern being raised about the non-recurrent nature of national funding for the suicide strategy. And I was wondering what the Integrated Care Service was actually doing in terms of funding the prevention strategy. I know you spoke about one staff member. The figures, the data that we've been given only goes up to 2021, which makes it difficult to assess the effectiveness of the prevention strategy, which only began in 2022. So I was wondering whether there was any reasons why there's no indicative data beyond 2021. But my main question was that one of the risk factors for suicide is being a worker in the NHS. And given that the NHS workforce is the largest single workforce in the country, and that so many people will be living in families where at least one member of the family works in the NHS. What is actually taking place at the level of the employers of health staff to try and address the suicide risks?
So there are a number of things in that. I get the frustration around the data. ONS data, there's a time lag, and that's why the most recent data is 2021. We are working with our data leads. We've got a suicide surveillance group where we're trying to see how we can use real-time data better and how we can enhance that. So that is a work in progress, and we're working towards it. In relation to the health and care staff, there's lots of work happening. Obviously, there's the West Yorkshire Health and Care Hub that anybody can access, and there's the crisis pathway that staff can access. But in the Adversity Trauma and Resilience Programme, which is why it's great that suicide prevention now sits in my portfolio, because I can bring all of this together, we have a health and wellbeing, a trauma-informed health and wellbeing task and finish group, and that's exactly what they're looking at. They're looking at how do we support staff that are on their knees, burnt out, compassion fatigue, trauma, vicarious trauma, all of that, which are all the causes of people then going on to take extreme measures to cope. So there's lots of work happening. We're just putting together a framework for that and how we're going to roll that out across the system. But also with the trauma-informed work that we're doing with organisations, we start with the workforce, because what we know is if the workforce aren't cared for, they can't care for others. So that knock-on effect about their own health and wellbeing is really important, and we're doing that with some really challenging workforce groups at the minute, as well as health and care in maternity, in A&E, but we're also working in prisons and across education as well, because the majority of the workforce across all sectors are in a similar position. So
it's the partnership picking up that funding stream that was provided nationally that has now come to an end?
No, not at the moment. We've got a couple of posts at risk that we need to do some work around, and the money that we have at the minute is through the SDF funding from Kia's programme for the bereavement service. Other than that, we don't have a budget, but Ian might be able to add more to that.
I mean, I guess just to clarify, Councillor Hutchinson, that the large majority of the core resource for this is in place. It goes to local authorities. It goes to places in West Yorkshire through core allocations. Em's referring to a sort of a slice of additional funding that we get specifically from NHS England called SDF, Sustainability and Development Funding. And there's a lot of, and this is kind of non-recurrent funding, and there's always a degree of uncertainty around it, particularly at this time of year, particularly when there's been a change in government with new ideas, new plans. I would hope, and we keep making the case nationally that this additional funding for mental health and suicide prevention will continue, but I think we're just flagging a risk there given the financial context that we're in.
Councillor Rhodes.
Thanks, Chair. Three brief comments made. First of all, mental illness has always been a Cinderella in terms of funding from any government, and we did see a bit of uplift, but not enough. You're reaching out with the champions, etc. Can I ask, in reaching out, obviously there's a new emphasis now on the support from job centres, and that actually brings in ability, educational needs, etc., and support more than before. It's going to be more targeted to the individuals now. Will you be involving yourself in these centres around the patches, because those people will need training and recognition themselves, and if there's somebody there that's trained to support, then I think that's invaluable. So that's the first question. The second one relates to education, and that is obviously those young people who are classed as NEETs, not in education, training, etc. How are you going to extend your remit into the education system across authorities? Do you have plans at the moment to do that? I'm always very receptive to presentations that says we will and we have and we intend. what I'm interested in is any written policies that you have that are both collaborative in terms of organisations and expecting outcomes within a period of time. Keir mentioned data. Collins mentioned data. We're going back years here. We've got to be a bit more progressive, I think, in the task and finish element of what we're expecting. So is there some data already available in terms of plans and processes? And I think I would relay my comment on all of those to the ICB in general. I've wrote down your 20 million. I'm hoping that we're going to see how the intention is of where that spend goes before plans are embedded in. And I'll comment of that to every plan and proposal in terms of the implementation process. So those are my 3 areas. And I think at some point, it would be good for us to have some reports, written reports on the verbal explanations of today.
I can answer some of that and then I'll hand over to Ian to answer the rest. In relation to DWP, we've got really good relationships with them, and again, the benefits of suicide prevention and the adversity trauma resilience programs coming together is there is an adversity trauma resilience national lead in DWP, and they approached us and want to do some pilots within certain job centres within West Yorkshire. So that will be going in, supporting the workforce, training the workforce, and obviously we'll go in there with the adverse trauma lens, which is vital in suicide prevention, but we can do the champions training at the same time. So we'll be able to combine and make the most of our time and capacity there. So yes, there is something happening in that space, and it's happening now. In relation to supporting young people in education, again, we have an education task and finish group for the Adversity Trauma Resilience programme. It's got really good representation of schools all across West Yorkshire, including higher education and universities. And we're doing a lot of work with universities to link up how we put policy into practice and how we can support practitioners in a more vocational sense. And particularly for young people that might not be as academic. So Leeds Trinity are doing a lot of work around that to support young people that are coming up through the system. The other thing we're doing is we're hosting a conference in the early spring to look at education and to look at what more we can do and how we can tie things together across both suicide prevention, adversity trauma resilience and serious violence, because they're all cause and causations of each other. And so that's happening. And Lisa Cherry is one of the experts that's coming in to support us with that, and she's a national expert. So yes, there's lots happening in that space.
Okay, and lastly to both of you and all presenters, in terms of the do's and don'ts and what is happening or proposed to happen, do you target yourselves with a traffic light system in terms of outcomes? And if so, I think it would be useful, every quarter or such, through the chairman, to present the traffic light system on outputs and expectations, or where things are not moving as fast as you would like, for information for us. Then we can always take that information back to our own authorities and use it through our local place as well.
Yes, so we have programme planning documents within all the programmes that are under my remit, with key milestones and key performance indicators. I've got various theories of change to show how we're going to get from one stage to the end outputs. And I'd be more than happy to share any of that. And I do regular highlight reports that go up to our oversight boards and groups. So yeah, all of that's in place, Councillor Rhodes, and I'd be more than happy to share.
Okay, thank you very much. Thank you, Chair.
Ian, did you want to come in?
It was just to make the point about the 20 million, Councillor Rhodes. I think that will go live from next April. We're developing the plan now. I think having a conversation with Scrutiny, getting your insight and input into that before April would be super helpful. So we'll work with the chairs to make sure that happens.
Yeah. Okay. Thank you. Right. Okay. So we talked about unemployment and the correlation with unemployment and suicidal thoughts, and the debt people with suffering debt impacts as well. and you talked about the accelerator for improving economic activity money, and obviously we've said that we'll having discussions as to how that can come into scrutiny for us to discuss in detail. We also talked about working in the local authorities with the education systems, and also about some written reports on the verbal explanations that we've had today. So maybe an expansion on examples that you've given, etc., would be useful, I think. And also about a traffic light system documents. Maybe, Ian, we can talk about how we can have those that maybe go up to committees, etc. But the main recommendation from today, we've had a proposal that the committee writes to the Chief Coroner in support of being able to improve data collection in respect of ethnicity. So does the committee agree that we should, as a committee, write to the Chief Coroner in line with what Leeds have already sent through? Is that okay with everybody? Can all the committee indicate, please? Yes. Okay, thank you. So Councillor Scope's officers will be in touch about your letter so that we can compose a letter from the committee. Okay, thank you. And thank you for that item. We will now move on to patient transport services, and Simon, I think, is hopefully with us.
I am, yes, Chair. Good morning.
Okay, good morning. Right then, so we've had your detailed report. Are there some things you want to highlight from that for us before we move into questions?
Yes, if I may. So four main points. So point one is around the impact of the criteria itself, and there is a fair amount of detail within the Transformation Committee paper itself regarding who we believe a change in eligibility criteria would affect. We can, of course, go through that, but that's my first point, that we can quantify that we believe this is around 3,600 individuals across West Yorkshire who predominantly would use patient transport for transportation to and from hospital outpatient appointments. So that's point number one. Point number two, some of which is reflected in the Transformation Committee, some of which isn't, because it's further work that's happened since we presented to the Transformation Committee, is the work that we're doing around the healthcare travel cost scheme. So one part of that is for individuals who aren't eligible for patient transport and then are using their private transportation. The Transformation Committee paper highlights that there is currently a variation in mileage reimbursement rates across West Yorkshire, which we are actively addressing at present. There are also pilots underway, and I must stress they're pilots to test the concept around prepayment for people using public transport. I accept and we accept all of the points that the committee made previously about the reliability and variability of public transport. So it's not the only option in town, but it's one that we are testing. And then thirdly, we are now actively looking and speaking to the voluntary community sector around their role in volunteer-led schemes for transportation for people to and from hospital appointments who don't qualify under patient transport, but don't necessarily have access to their own private vehicle in one shape or form or another. So that's that point two, which I'm sure that there'll be questions on. Our intended position is that all individuals eligible for financial support should receive that, and should receive the support consummate to their needs to actually physically get that. And we'll talk a little bit about that in a moment. And that there should be consistency in on-day reimbursement for individuals. It shouldn't be dependent on which hospital site they go to and knowing where the cashier's office is. That point then said, so we are engaging with the voluntary community sector and have lots of positive engagement thus far around their potential role in administering and helping us administer volunteer-led transport schemes. We have applied as part of a national pilot to remodel a healthcare travel cost scheme, which includes how to make more people aware of it, how to create consistency, approach and ease of administration. In that, we submitted that last week to NHS England, and hopefully we'll be successful. So we've submitted as part of an overall Yorkshire and Humber region to hopefully strengthen our case to actually physically therefore get support for that. The hospital trusts and the West Yorkshire Association of Acute Trusts are currently piloting their bus and prepayment bus ticket approach, and that will report in the new year. And we're also actively engaging with those members within the West Yorkshire Association of Acute Trusts around the points that the committee previously made around timing of outpatient appointments and how that links to travel preference and ensuring that people have got the best possible chance of actually physically getting to their appointment. And that, in conclusion, is my 4 points. Thank you.
Thank you for that. Can I just ask a clarification of just one point? The Transformation Committee therefore approved in principle to move to this new national criteria. The Transformation Committee did not push back against this national criteria and say, in actual fact, we want X, Y, and Z in West Yorkshire. It was a in principle agreement with that national criteria. And just for clarity before we move to questions.
Yes, so it was, they didn't push back on the implementation of the criteria itself. They supported in principle, subject to me completing all of the actions that are stated within the committee paper itself. And therefore, I'm due back to report to the committee in February next year.
February, right, okay. Thank you. Right. Any questions on this? And I know there are. So any questions on this item, please indicate. Councillor Hutchinson.
Yeah, I did, you know, it strikes me that when you take into account the cost, the increased cost of call handling and administration, and the potential impact on workflow in provider organisations like acute trusts, if there's going to be an increase in non-attendance rates, particularly if it's going to cause any disruption to surgical operations, because in a lot of trusts, people are admitted on the day of surgery, so they need to actually be there in time to get their operations. Otherwise, they're going to have to be rescheduled for another time, which is a cost. That the saving, has anyone looked at the cost effectiveness of this strategy, whether the savings are actually going to outweigh the cost, the additional costs that will be put on the service?
Yeah, so I think the first point is that this isn't a cost-saving exercise in itself. This is a national review with a recommendation to have national criteria across the country to reduce the variation in eligibility criteria that currently exists across the country. So I do want to strengthen that point because you know, that is there. In terms of the actually addressing the question itself, there have been assumptions made previously around implementing the new eligibility criteria will increase the number of call handlers that were required in the ambulance service and the cost thereof. I think it's fair to say we've been actively challenging those assumptions to make sure actually they're the right assumptions to make. In terms of assumption number one is that they need more call handlers because the amount of time on the phone will potentially increase by 10 minutes. When we've gone through that and I've challenged that and worked with them on that is still the discussion. That I can't personally at present see any quantitative evidence that suggests calls would increase by 10 minutes. But number two is the assumption that therefore the ambulance service would hear the right of appeal, which again is an assumption that we're challenging because any right of appeal, from my personal point of view, should be independent of the person that you're making the appeal against. Therefore, we are still actively discussing whether there is a need for additional call handlers and actually whether the ambulance service could meet that any capacity within their existing complement of call handlers, because within the ambulance services overall contract, that pays for a number of whole-time equivalent call handlers. So are there any efficiencies in the way that they undertake their business that actually would deal with that matter? In terms of overall, would this potentially make things more inefficient, more ineffective? I haven't personally found any evidence of that as yet. It's a very difficult question to answer. being objective in the sense of we haven't actually got any data on that to test. But what we have been able to do is say, we think it's 3,600 individuals. We think that equates to just over 12,000 outpatient journeys. We can see what that would potentially do if all of those resulted in DNAs, what that would do to the overall DNA rate across, or did not attend, sorry, rate across West Yorkshire Trust. And we are actively looking at other healthcare travel cost schemes in terms of there are certainly some economic efficiencies I believe we could make around the healthcare travel cost scheme. We'll come on to that, I'm sure, in a moment. But at present, we don't believe that this necessarily costs more than the current method of operating that I've described.
I must admit, I find it difficult to believe that there isn't an intention to save costs, and that this policy is just for tidiness' sake across the country. But I was interested to see that the range of payments for mileage payments for volunteer drivers and the variance between the different trusts. I mean, one of the charities that I work for with that I'm a trustee for, the people with visual impairment, the volunteer drivers are paid 45p a mile. Calderdown and Huddersfield Foundation Trust is about 15p a mile, a third of that's on offer.
Yes.
And, you know, again, if we're going to anticipate that there's going to be an increased demand use of volunteer drivers, that will add to the provider's costs.
Yes, so where I think there are, Councillor Hutchinson, efficiencies to be made is there are schemes up and down the country for volunteers that either pay 45 pence per mile or 50 pence a mile, depending on how you interpret the mileage reimbursement rates from the inland revenue. All of which, as you say, are higher than the current rates of mileage reimbursement if somebody was claiming directly from a hospital trust, for example, in West Yorkshire at present. But I genuinely believe, and I'm writing the business case for this at the moment, my hypothesis is that the administrative costs around volunteer-led schemes would be lower than the administrative costs that the NHS, the Department of Work and Pensions, the NHS Business Services Authority all have to get involved in when dealing with claims through the healthcare travel cost scheme. Some of that won't be necessarily therefore a direct economic benefit to the West Yorkshire Integrated Care Board, but that's what we're working through at present in the sense of how do we make something administratively easier for people that makes better economic sense in terms of use of taxpayers' money and allows more people to actually physically access it. That's what we're working to. But in some cases, some of these things have got their tentacles, and this is not me being defensive, in 10 years worth of history. I'm picking them up in the last 2 months and being open and honest with people and saying this variation exists and we need to address it, and that we will. But it is going to take a little bit more time and analysis to work through, including when some of the information we ask for has to be done through freedom of information request, because actually other parts of the NHS, for example, the Shared Business Services Authority, won't give it to me unless I put a freedom of information request in. So that's why we want to be part of that national pilot to simplify and tidy up the healthcare travel cost scheme, because we recognise that there are things we need to address. But some of them do have a long history, unfortunately, too.
Okay, Councillor Hutchinson. Yeah, I think our point is, and I think our point is, isn't it, Councillor Hutchinson, that you in this scheme you've got a reliance on volunteer drivers, and if you do not have the payments correct, then that reliance isn't going to translate necessarily into volunteer drivers. Absolutely. And this is one of our concerns about this project, that reliance is not going to materialize, and we're going to be in a difficult situation as a result.
Yes.
Councillor Rhodes.
Thank you, Chair. Hello, Simon. Just going back on the issues of the volunteer drivers, etc., etc. First of all, obviously you or the authority involved will have the detailed names and contacts and the expected workload in terms of turning up for clinics or whatever it may be. Do you have a plan B in case those drivers on a set morning or whenever it may be through the day can't make their duty and you have an emergency on your hands? What do you have in place for those situations?
So I'll be honest, we're still working through that. What we're trying to do is try and create a range of options. So what we're trying to say is, if we just sequentially work through it, so for people who meet the criteria of patient transport, they will get it. So for people who require for renal hemodialysis, they will get it. For people who've got significant mobility need, as defined within the report, but just for the avoidance of doubt, people who need more than one person to help them enter safely or exit a vehicle, they will continue to get patient transport. Anybody who's got an issue or a concern around individual safety or medical safety, they will continue to get patient transport. So they will always be protected in that regard. For individuals,
okay, can I just stop you there, because we're speaking about you're speaking about those that have exemptions, etc., in terms of the plan at the moment, and those that need two people, two ambulance people, etc.
Yes.
What do you have in place if that system needs somebody else to come in? Because I do know that over the years, in terms of transport for patients and indeed transport for patients through either 999 or whatever, they're still being queuing up at hospitals.
No,
so where are all these going to come from now?
Apology, Councillor Rose. It's probably how my brain works, but I wanted to explain it all in one go and then kind of just explain how it all fits together, really. So I was starting right from the outset, and then I was going to work all my way through, which, if that's okay, I would like to do. So transported there for people, as we've defined, for people who really, really need it. But individuals who've got their form of private transport and are willing to use their form of private transport, we want to make sure that actually their rate of mileage reimbursement isn't dependent on which hospital trust they go to in West Yorkshire. So that's point number two. Point number three is what we're piloting at the moment, is giving individuals prepaid bus tickets where that's appropriate and where individuals feel that's appropriate, to therefore enable them to transport themselves to and from their appointment. But we're piloting that at present. The use of the volunteers is a new idea to us anyway within the ICB in terms of contracted services, and therefore we're looking at that as a fourth additional option. So how I wanted to present it was actually it's a suite of all of those options together that we're hoping brings in the resilience for this. And therefore, we'd keep that under very close monitor, and we'd continue to review that to see actually whether it was meeting what we wanted it to meet. But when we look at any one of those options in isolation of one another, it is easy to say, well, what's the pros and cons of that one? What's the pros and cons of that one? What's the pros and cons of that one? What we're trying to do is build one overall approach that has a range of options in it that is suitable to individuals' needs. And if any case where that doesn't materialise and meet people's needs, we would want to know about that. Because we are trying to take on board all of the feedback that the committee gave us last time, which was, for example, don't be overly reliant on public transport. I'm paraphrasing here because of some of the issues that exist around public transport. But equally, as we've delved into it, we've found that differential mileage reimbursement rate. We know from the information and the FOIs that we know how many people are qualifying under the healthcare travel cost scheme and how many claims are being made by every single postcode across West Yorkshire. And therefore, we know which postcodes aren't submitting at present claims through the healthcare travel cost scheme, which then allows us to start to target those communities and work with partners in those areas. And if anybody would want to see that and understand it from their geographical area of responsibility, we have that information. now. So we've got a level of detail now that allows us to start doing some of these things. But each one on its own doesn't necessarily provide the full solution and the full answer. What we're trying to do is bring them all together and test all of it. And we have to also hold the ambulance service to account when they're applying the eligibility criteria to ensure that they're applying the eligibility criteria should it all go through and be approved in April in a fair and consistent manner.
Well, I'll come back on there, Simon. Yes, I mean, there are these options which fit nicely into some package. But in the real world, it's different. It's different out there in the real world. When I'm delighted to hear, because I'll be checking with my ambulance colleague in Wakefield, I'm delighted to hear that there's such resilience within YAS that can take this on board without any extra cost. I'm delighted, but I'm honestly going to question that because you've actually, and as the chair has said, you've agreed to support in principle the implementation of the national strategy from the 1st of April. Your report actually tells us, and you've said it here today again, your next reporting mechanism is in February. Now, can you tell us then, you've got January and February coming up around the corner. Can you tell us what's going to change between now and February? Or is this additional information that would be useful to us in looking at this all-round great picture? The potential for prepaid bus tickets, I'm going to go through them one by one, if I may. The potential for prepaid bus tickets is a great idea. We put that forward. But since our last meeting, I can tell you, and the statement was made that this change should not be dependent on public transport. I can tell you around Wakefield and the rural areas, and I'm not on my own in this in terms of transport, through the franchises from privatisation, we have had bus routes cut off here from Wakefield. We have maybe one bus an hour. And when we're looking at YAS being so able to continue with people, then I think there's a bit of a myth about it at the moment that it isn't a cost-saving exercise. I think the issue of volunteers and your representation here today about the admin costs and how in claiming back is an admin cost to the trust. Of course it is. Everything that goes into health in terms of admin is a cost to the trust. But by this method now, if I've taken it right from your interpretation, the cost and evaluation and responsibility now falls on the volunteer in terms of the HMRC, in terms of their responsibility on declaration, etc., etc., etc. So they're going to be the ones that will pick up the cost in declaring to the revenue. And in terms of admin costs then, as there were before, where there was staff associated with them, because there has to be, what's going to happen to those staff? Where are they going to go? You're taking away an area of workload that you said was overburdened with costs and can be simplified with this system. What's happening to those staff? Where are they going to go? Are they going to be lifted and filtered into some other part of the organisation?
Okay, so you've asked me a question, what's going to change between now and February? So what I would expect to change between now and February is that we get a consistent rate of mileage reimbursement across West Yorkshire.
Good.
That we will hear what the pilot is of the prepaid bus tickets, and we can then make an informed decision to the extent to which we believe that's worked or not. That we will either be part of a national pathfinder to simplify the healthcare travel cost scheme, or if not, we will do that ourselves, and therefore we will change that approach. In terms of the points around the ambulance service, this is about ensuring that the ambulance service can cope well with the demand that it receives, particularly for those who are complex and most in need of patient transport. The financial mechanisms in the contract with the ambulance service do not work in a way where we pay for per journey or per vehicle or anything of that shape or form. Therefore, we wouldn't be able to remove costs, even if the demand reduced in that way. That would be a separate conversation. But what we do want to get the ambulance service to in a position before April next year is that we're really, really clear on call handlers and the capacity of call handlers and the performance of call handlers, because we already pay for call handlers and we already pay for call handling performance even before we talk about a change to national eligibility criteria. So that is a routine conversation that I'm picking up with them as part of the contract renewal process in advance of 25-26. So we're having that conversation anyway. So I would expect us therefore to get to a very clear position and a very clear set of expectation around the current complement of call handlers that we're currently funding through their contract and the performance that we would expect in terms of that call handling capacity and how we best want to use it. And there are other options as well to minimise demand on call handlers that we can explore. So, for example, without going into too much detail, for healthcare clinicians, they can book requests for patients through an online service, but at present they can't do that for all requests. What we're pushing the ambulance service is to say, well, can't that be for all requests from a clinician, because that would then free up capacity with the call handlers to therefore better respond to the public when they're seeking to make a request for transportation. So therefore, I'd expect to get to a very clear position in that regard. In terms of the administration of the scheme, at present, for the Integrated Care Board, who receives the travel reimbursement forms, that comes into my team as an additional workload on top of their workload already. So it's not that individuals are spending all of their time doing that. That's an additional job on what they have. In terms of hospital trust staff, in terms of their cashier officers, for example, it would depend on how successful we are at mitigating the need for individuals to go to a cashier's office anyway, which is dependent on whether we can get a volunteer workforce across West Yorkshire or not.
I'm not being rude, Chair or Simon, but if you see me manoeuvring around here, it just tells me my battery is running low, so I'm trying to connect at the same time.
Nice. Thank you.
If you forgive me, I'll let somebody come in while I connect and then I'll come back, Simon. Is that okay? Thank you.
Ian, you wanted to come in. I just wanted to ask as well, just before you come in, this, because you may have a view on this as well, this information you've got from this third party that you will need more call handlers. Is that in the interim until this settles down, or is that going to be long term? Because I can see that if people have received transport before and then they ring up and they say, can I have transport, whatever, and that is said, no, you don't. I can see that being a longer conversation for quite a little while people see the change coming through impacting on them. So what I'm wanting to know is it a short-term increase or a longer-term increase?
So yes, it's how it's presented is a non-recurrent or a short-term increase to directly answer the question. But what we're doing is, and I think this is fair and right practice when we're spending taxpayers' money or potentially spending taxpayers' money, is we're going back and revisiting the assumptions that were made to reach that conclusion in the first place from the third party. And we're looking at broader overall efficiencies around the use of the call handling capacity. For example, ensuring healthcare clinicians can book when they want all forms of patient transport online, as opposed to having to go through the call centre, and trying to make a distinction that the call centre should be public facing, the website and the online should be facing towards the clinicians, because clinicians themselves don't want to spend time on the phone. They've got other things to do when they could submit a web form. Yeah. The overwhelming feedback we get from clinicians is we want to use the web form. So it feels like we could get a double win in that regard.
Okay. Ian, you wanted to come in?
Yeah, I just wanted to make a point in relation to the role of the Transformation Committee and the point around approval and in principle, really. I guess just to provide a bit of reassurance to this group, we've had 2 or 3, I think, really detailed, robust debates at Transformation Committee on this. I think the way it was left at the last meeting was that, subject to the work that Simon's described being done and the committee being assured, they would then be in a place to support this. But it's absolutely not that, you know, this is being waved through without proper consideration and discussion. Fundamentally, as Simon's described, we've got a demand for patient transport services, which is rising quite rapidly across YAS, and the role of the national criteria is to help ensure that the people who most need that patient transport service are able to get it and are getting it. The work that Simon's doing, and it's really complicated and it's quite intricate as we're describing, is ensuring that in changing that so that that group gets the patient transport services in need, we've got appropriate arrangements in place for the 3,600 who don't get that. I think there are helpful byproducts that will come out of this work anyway, like the harmonisation of rates across trusts, that the healthcare travel cost stuff. So the stuff that will benefit anyway. But just to provide that assurance, I think that it's not that this has been waved through by the Transformation Committee, and they are having conversations like this in that forum as well. It's a topic that we're all absolutely know that if there could be negative consequences of, and we need to be absolutely assured that the work's being approached in the right way.
Yeah, thank you. I think as long as the harmonisation, when you say harmonisation of something, it usually means it goes to the lowest denominator. And I don't think that would be at all fair. I really do not. Can I ask about you mentioned about your did not attend.
Yes.
And in your report, it gives, but this would only be certain percentage of the total appointments, etc. But you're working with the trusts to see how their appointment system can be adjusted.
Yeah.
Is there work? I would have thought there would be work already ongoing on the did not attends as a whole system, and then this is going to add to that work, presumably. And so how is the discussions with the trusts ongoing about the did not attends and finding out the reasons for those now, and whether any are in relation to transport as it is?
Yeah, so I attend a elective care coordination group, which is led by the West Yorkshire Association of Acute Trust, and I attend at least once a month, sometimes more frequently on that, depending on the topics of conversation. I think it's fair to say that the reasons for did not attend are multifaceted and complex, and it's very rare, in my experience anyway, having done a multitude of roles across the NHS, across a variety of providers and organisations, that there's only ever one single reason why someone did not attend. It's normally a combination of factors that have led to that. And we've got also other broader things to consider within this, and the West Yorkshire Association of Acute Trust are aware of this, in a sense of ensuring that people are being recalled to hospital when it's actually really, really needed, and actually there aren't other ways of doing that in terms of telephone appointments, just as an example. But yeah, I'm meeting with them all the time on that, and we're going through it. Part of the reason why the West Yorkshire Association of Acute Trust wanted to look at the prepaid bus ticket is because they believe that will reduce did not attend, because they're looking at it from a point of view that some individuals don't have the money in their pockets in the first place to be able to get onto public transport or put fuel in their cars. Hence why they wanted to look at prepayment bus tickets. And that's why we're keen to understand in the new year, when that reports, what the findings of that work are. So once we get into hospital appointments and we get into the number of hospital trusts across West Yorkshire, it does become a much bigger project by its very definition, because there's hundreds of thousands of appointments made every year across numerous different autonomous organisations who all do work slightly differently in how they do their appointment systems, and even within their own organisations do things differently between departments. So there is quite a lot of variation for us to work through and tackle in that regard. But I think it's fair to say to the committee, there isn't one central way of writing out letters and appointment systems across West Yorkshire, across the trusts. You could have variation between two neighbouring departments in one hospital within West Yorkshire, even before you consider between hospitals themselves. So we recognise the points and we recognise the challenge. It's just going to take us a little bit longer to work through all of that because of the size of what it is.
Okay, so the things you have to do by February, presumably that's when things go back to the Transformation Committee.
Yes.
Do you believe that you will have all of those strands in place in February?
Yes. Otherwise, I don't want to be. Unfortunately, I've made somewhat of a career of taking on the big complex stuff, and I took this project on in late April. It's got a long history to it, which I've reminded people of it. In my 10 years prior, I don't think I heard anybody talk about transport in the way that we're talking about transport now. I think us talking about transport and working through the problems and issues around transport is a great thing. But we're not at the finish line yet, where we need to be judged on are we where we want to be at this point in time, not where we want to be in overall terms. So I think in terms of the plan to get us where we need to be in February, yes, we're on track.
Okay.
But we haven't achieved everything that this committee wants us to achieve.
Yeah.
Because that's our future plan.
Okay, Councillor Rhodes.
Thank you, Chair. Well, a recognition that it's going to go ahead in April and I was very interested and wrote it down, a National Pathfinder Scheme project.
Yes, that's right.
Is that why there's a rush to get it started in April? Or is it that you're confident that you're telling us today that all of those issues are going to be strong enough, identified enough to support the plan that you have, what was the word? You've summarily anyway agreed it in principle. So what is going to be left to be the final document then? Because you've gone forward in principle, so you have to have a final agreement to be on a National Pathfinder Scheme. So you're saying that not all of them may be, but is that going to affect your National Pathfinder project? Because I don't think there's one of those going that says, well, you haven't got it all now, but we'll wait 6 months to see if you have. That's one thing. Secondly, I think you were mistaken in terms of the cost analysis I was looking at. You've got an assumption that the operators that you're paying in contract to Yaz have spare capacity to take on board the extra demand of calls that is going to accrue through this project. My cost analysis was that in taking away the responsibility for the financial statements in terms of revenues and all the rest of it, that's going to be a reduced cost to the trust, but the volunteers are going to be taking that one on. So tell me more about the National Pathfinder project, please.
Yeah, so 2 points there. So the National Pathfinder is something that's been set by NHS England because people like me, for example, have gone to NHS England and said the healthcare travel cost scheme is complicated. People aren't aware of it. They don't know how to use it. And we've got very clear...
Excuse me butting in there. Did you go as an individual on behalf of who?
So the national team actually came to me because they heard of the work that I was doing. And they said to me, what do you think about the healthcare travel cost scheme? And I showed them a process diagram that I'd drawn out of all the stages that people need to go through in this process. I showed them the freedom of information request that I've gathered in terms of how few people actually are accessing the scheme across West Yorkshire currently. And they said, oh, that's very interesting because another trust in the north of England, Sunderland, have started to do some work in this area. We're going to take all the points that you've taken away and we're going to think about what's the basis for change. What they've then done is opened up a national pilot scheme and asked for applications where we can bid to be part of that work, to receive some money, to get us some capacity, to help us understand and implement this scheme better. I think that's a very positive move from West Yorkshire, and our colleagues in Yorkshire and Humber have joined us because we want to strengthen our bid. We really want to do this work. We really want to be successful in this area.
I'm sure you do, Simon. Just another qualification, Chair.
Yes.
Is that your portfolio of employment within the ICB?
In terms of me as an individual, so so
Yeah,
I'm
your job. Yeah.
Yeah, so I'm an assistant director of contracting, and there are 4 contracting portfolios that exist, and I was at the 1st of April allocated to this portfolio of work. So yes, to answer your question, this is my portfolio of work from the 1st of April until I'm told otherwise.
Okay, I just wanted to know where you were coming
don't want to
from,
get
because
into personal things. Yeah.
No, we needed to know how this procurement was advanced, Chair. That's important. It's public money. We need to know how it was advanced. And lastly, Simon, I was very sorry to hear, and I say this genuinely, in respect of the work that everybody does. I was very sorry to hear you state that in the last 10 years, patients' transport was nowhere around. It wasn't a big thing, basically. And it's come about in this last year or so. Well, I can tell you this much. From the people out there who've been using it and need to use it, people who have amputations because of diabetes, I can go through the list. From people who have had to use it over the years through their need. It's not been a small thing to them, I'll tell you that much. And how they've had to, wait a minute, let me finish. And how they've had to circulate to get the ambulance service, the transport that they need. I don't want anybody to walk away from here thinking it's been easy. It hasn't been easy. It hasn't been easy, but it's been good to have the debate with you today and meet you and to actually know where it come from, and that there's a financial incentive that we didn't know about, Chair, a financial incentive as well, to be part of some resources in terms of the Pathfinder scheme.
Yeah, I think if we can get into that pilot, that would be a positive help.
Absolutely. There was another point raised, Chair, about cost benefit around the call handlers, if I may. So we, as an ICB, already pay the ambulance service for X number of call handlers. It is right and proper, as part of the overall contract that we already hold with the ambulance service, to discuss with the ambulance service their recruitment to those number of whole-time equivalent posts, how those posts operate, and their overall level of performance before any additional investment is considered. And I'm sure everyone would agree with me that that's a good way to approach the use of taxpayers' money. That's the conversation we're having with them at present, to test those assumptions that have been made by a third party, not by us directly as a West Yorkshire Integrated Care Board, to say, well, actually, it's right and proper if a third party's made a series of assumptions and then somebody's seeking additional investment from us for us to test those assumptions. And that's what we're doing. And we want to ensure that we've explored all opportunities within the existing staffing workforce to do things as efficiently and as effectively as possible, which includes ensuring that healthcare professionals don't need to ring the call centre when they actually could make their request online, which therefore reduces some calls to the call centre. And that's what we're looking at. And aside from my flippant, I can't even say it, but regardless of being flippant about the last 10 years and putting that kind of casual point to one side, it is a really, really important area of work that has grown in its profile and its awareness and its need to do something differently this financial year. And I think that's a really good positive thing. The past is the past, unfortunately. But what we want to do is raise the profile of transportation and make sure it's an integral part of delivering healthcare services. And people are always thinking about transport when they're seeking to commission or redesign services. And that's where we would like to be.
I'm equally very versed in the role of procurement and contract, Simon. So I don't think I needed a lesson in that.
All right. Okay. Thank you. Okay. So I think we'll bring this discussion to a close then now. So I think we covered the cost of call handling, and you're going to do some more work in relation to that. I think we'd like to understand how that's going to be a robust system, and also the right of appeal that you talked about. I think you mentioned about it being an independent right of appeal. I think we'd be interested to know how you were proposing that was going to be.
Yeah.
Your payments for volunteer drivers, we discussed about the volunteer driver situation, and you said you were going to do a business case on that.
Yes.
So again, some information on that, on your volunteering. And the piloting on the prepaid bus tickets, you said you would have some findings on that, but
Yes.
you had your differential mileage for people who were claiming and who are not claiming,
Yes.
from postcodes, and I think it would be interesting to know whether those are from areas that maybe deprived areas or not, where if you can identify any barriers in the system to people who have not been claiming. Maybe English is not the first language, or the signage in trusts, etc., is such that people do not understand that they can claim. And I think it would be interesting to know how you're going to develop that area, so that there's more uptake in that. And the transformation committee, the items you're taking back in February. I think, Ian, if we can have a discussion, please, as to how Scrutiny can look at those things and put some points to your transformation committee. Unfortunately, I can't see a date for that transformation committee online, but if we can have that discussion as to how we can input our recommendations into that, I think that would be good. But we'll take that out of the meeting, Ian, if possible. Colin and I can have a discussion with you, and then we can let the committee know. Okay.
Absolutely, but we're more than happy to have a page as an annex of the things that you have covered and that we would like to see as part of the finalisation of this, and we're comfortable with that. Thank you.
That's fine. Thank you ever so much. So that brings this item to a close. At the moment, we have our next meeting planned, which is in February, so I just leaves me to say wish you all a Merry Christmas if I don't see you before, and thank you for your attendance this morning. Thank you.
Chair, before you sign off, can't we just have our meeting to coincide with the requests that you've had for further information to come back in February?
Yeah.
Thank you.
Yeah. We'll sort that out. Okay. All right. Thank you ever so much, everybody. Thank you. Bye-bye. Bye.
Bye.
Thank you.